Awesome. Hi, welcome to Casual Conversations, the weekly show where I interview brain injury professionals, advocates, and people who have experienced brain injury with a live audience, and then the show will be on YouTube. All our past shows are on YouTube on the Pink Concussions channel, and we thank IBIA and NABIS for the platform and all the hard work by the NABIS crew to get us ready every week. So today I have a very exciting show with someone who I have known for quite a long time and someone I just met, Alina and Jaycie. So Alina, where did we first meet? I can't even remember because you've been a part of really every event that Pink Concussions has done.
I don't remember, honestly, Catherine. Did we meet before we were in San Jose?
I can't remember, but you packed up a bag and came over to our event as part of IBIS in Rome. So that was the third one. So I don't know where we came across each other.
I think I met you before that. I met you in Northern California at some conference before that. You know how we met? We actually met through one of my past patients who lives in Utah.
Oh,
that's how we met, but I don't know how long ago.
And she gave a shout out and introduced you at Pink too. Well, okay, so we go back to San Francisco at Palo Alto, at the Palo Alto VA in that was fall of 2016. So welcome to the show, and who have you brought with you today?
So today, this is my colleague, Dr. Loewen, Jaycie Loewen. She is one of my neuroscientists at my clinic at Cognitive Effects. She is just a gem. She's smart. You know, I heard once that if you're the smartest person in the room, you're in the wrong room. So I had to hire Jaycie because she was way smarter than I am. You know.
Well, welcome to the show, Jaycie. Very happy to have you.
She keeps me on my toes. She has a PhD from University of Utah in neuroscience. Jaycie, do you want to introduce yourself a little bit?
Yeah, so I come to this with a bit of a more basic science background. Like, you know, you think of those crazy movies where people are doing experiments on mice in this big lab. I was one of those people. I'm glad to have made the transition into more clinical, where we're working with actual patients. Alina's been my mentor into the realm of concussion as well as other types of brain injuries, but it's a very rewarding position and also very interesting because we can still talk about a lot of science.
That's awesome. Well, thank you. And I'm glad to have you today and glad to meet you as part of this show. So I'll swing back to you, Alina. Tell me where you grew up and how you became interested in science.
Well, where I grew up on a little island called Hawaii. Some of you might know it. I was fortunate enough to grow up there. I actually went to one of the few private schools on the island, but it was the one where you had to be part Hawaiian to attend. I'm curious how many of you guys know what school that is, and no, it's not the one that Barack Obama graduated from. You know, people are like, oh, it's Punahou. No, I graduated from Kamehameha High School, and it's interesting because in Hawaii, they care more about what high school you graduated from than what college you graduated from. If anyone asks you back home, oh, you know, where you graduated from, they want to know what high school, not what college, you know. So I was fortunate enough to graduate there. Then I grew up there, spent all 18 years of my life until I came here to Utah, to BYU, and did all my graduate work here and undergraduate work, and I just kind of stayed, you know.
Were you always interested in science? Were you always interested in science growing up?
You know, I was enthralled with my AP psychology class in high school. You know, I mean, that was kind of the first foray into a field that I felt wasn't already done with, you know, we didn't know everything about everything, you know, back then, but, you know, we knew about like history, right? I mean, we knew about English and grammar, but with psychology, I was like, oh my gosh, this is amazing, you know? So that kind of piqued my interest. And then when I came up here, you know, to Utah for school, and I started to get into neuroscience classes, that's when I was like, oh my gosh. You know, when you think about it, we know what the heart does, we know what the lungs do, we know what muscles do. We still, at that point, we're like, gosh, we don't even know for sure what the brain does, you know, and how it really works. And we haven't, it's kind of like uncharted territory. So that's really what pushed me in that direction was this desire to discover something new, or something different.
Which very much explains the career that you've chosen for yourself. What about you, Jaycie? Where did you grow up, and what was your track into science?
Yeah, so I actually grew up in the boonies, a little town about 30 minutes west of Salem, Oregon. I grew up on a farm, actually, and was homeschooled. So I'm one of those kids. I was lucky enough to be able to actually go directly into undergraduate. My family moved to Flagstaff, Arizona, so I managed to go to Northern Arizona University. And then after that, spent some time working in some labs. I'd been very interested in mathematics, actually, theoretical mathematics, but then eventually found that if I actually wanted to work with people, then I needed to go down a different track. And I'd always excelled in biology classes and physiology classes. So that eventually led me, very similar to Alina, where it's like, well, what don't we know yet? And the big answer there was the brain. So I ended up going to the University of Utah, studying their neuroscience program. I actually ended up joining a lab where we worked on epilepsy models, so seizures, viral-induced seizures. So that's actually what we're going to be talking a little bit about today, is viruses. And then right after I graduated, I took some time to just relax, and then ended up having a peer of mine send me an email about cognitive FX hiring. Went to interview there, met Alina on the second day, I think, or it might have actually been the first day. I don't know, but met Alina very soon. Loved the clinic and have been working there ever since.
That's awesome. Alina, so let's go back to you in graduate school, and tell me what's fascinating you and how that led you to where you are today.
Well, BYU is where I did all my graduate work, and not a huge university. Well, actually, it's a pretty big university, but I was so fortunate. I stayed there for my master's and my graduate school because of the opportunity to work with Dr. Erin Bigler, who some of you know, he's probably one of the foremost neuropsychologists, and kind of paved the way with imaging. And Erin actually told me I was the only neuropsychologist in my entire cohort, because when you get a PhD in neuropsychology, for those of you who don't know, you're a clinical psychologist, and then you choose a track. So you still have to get all your clinical psychology training, but then if you're a neuro emphasis, you have to do extra coursework to do neuro. And I was the only one in my cohort of, I think, eight or 10. I think 8 by the time we were done. I think a couple dropped out, right? That decided to go neuro. So I had the opportunity of being with Erin Bigler alone, for most of my schooling. And I remember him sitting me down and just saying, if you really want to make a difference, you personally learn some imaging, because that's kind of the future, is being able to see functionally what's really going on, and of course his career has taken him through Fmri, through DTI, to SWI, just pretty much every advanced imaging modality that there is, he's co-authored.
Just and I want to stop, because he really is such a significant person in history. Can you just give a little, one sentence on what each of those acronyms mean?
Sure. So Fmri is functional MRI, and actually Jaycie and I are going to talk about that ad nauseum today.
Okay.
DTI is diffusion tensor imaging. And I have two colleagues that also studied, two really good friends that studied under Erin as well, and they specialize in that type of imaging, if you want to talk to them, and then SWI is called susceptibility weighted imaging. And so these are all techniques that are, you can use a regular MRI machine, but they just give us so much more data than just regular pictures, just structural pictures, So, these areas, these types of imaging modalities, I mean, if you were to do like a PubMed search on DTI, there's thousands of articles now, Fmri, thousands of articles, because it's kind of this emerging, I wouldn't say emerging, since Fmri has been around for over 30 years, but DTI is newer, SWI is newer, but these are cool new imaging techniques that allow us to see what we never could see before with regular structural imaging.
And I think this is so key. I've always been looking for, I want to see the differences between male and female, why there is a structural difference for women that for when a brain injury happens. And it was Doug Smith's work to finally get that image, because we are all interested in brain injury, which is the invisible injury, the invisible patients. And this imaging is so key, because imaging plays a role. When you can get the right image, then you get diagnostics, you can fight your insurance company, you can back up a lawsuit, you can show all of the things that the invisible injury doesn't allow you to show, where if you had a broken leg, you can show the x-ray. So that's why this imaging is so incredibly important. It's expensive, it's hard to access for not every, could you just talk a little bit about how accessible these particular scans are?
Sure, and can I just shout out here? I'm looking at the chat, and she posted to everyone, so I can say it. But Allison Walkowski actually is on the chat, and she came to us a year ago for concussion, and so I just want to tell her thank you for being here. Our patients mean the world to us, and I'm so glad, Allison, that you were able to come. So, as far as accessibility, yes, we are in Utah. So like Allison, she had to fly to Utah to get scanned and to get the treatment. As far as cost goes,
actually, I was speaking more general. I mean, you just mentioned a bunch of different scans out there. So if
okay.
Some, or even a researcher's like, I'm really interested in that, who has these particular scans available?
They're available. Jaycie, you can chime in on this too, but I know that the Department of Defense at NICO, they definitely do Fmri, and they use that clinically as well. I know most hospitals, if there's a research facility, they use Fmri, they have access to Fmri. Jaycie, do you want to chime in?
Yeah, so I would say that probably most, at least, if you drive around your city, you're going to find a hospital with functional MRI. I mean, it's used for example, if you're doing a tumor resection in an epileptic patient, so there's a part of your brain that's causing seizures, you need to get them in that functional MRI and map out so that you can eventually get into that brain and take that part out. Same with tumors, for example. Now, I would think that the limiting factor is that it's a big magnet. So you have to have a special enclosure for it. You have to have technicians to run it. It's expensive. So I would say that, other than the limiting factor of, time, money, and space, I think more clinics would have them because they are so useful.
Now, I have been in your functional MRI. Gosh, what year was that where I came out to Salt Lake?
That was like 2, maybe 3 years ago.
And so I prepared, I've been in MRIs before. I went into the tube and then I had to open my eyes, which was something I don't usually do. And then there were several different mirrors, and there was basically kind of like questions like an SAT and different questions that I had to do for about 45 minutes. And I didn't like being in the tube. So they drew me out again, and I'm like, all right, I can do this. I am not walking out of this. Went back in. And once I got engaged in what we were doing, it was really fascinating. Yeah. So tell us a little more about, how you're using fMRI, your clinic, and with who, and then we can segue to the COVID piece that you're working on now.
Well, what I want to do before we get into that is talk about how we're on Gen 2 or Generation 2 of our scan. So actually, Katherine, the scan that we use now is vastly different from the one that you went into, and I'll have Dr. Loewen go over that.
Yeah, so Katherine, since you have an insight, I'll try to speak to both the crowd that's going, okay, that sounds like very futuristic, as well as to those that have experience with it. But in our first iteration of the functional MRI, obviously it's a task-based functional MRI. So you're getting in there and you're doing stuff. And during that scan, it would be about 45 minutes in total. You're answering all these questions. There's also these, spots where you have to shut your eyes and count to kind of reset your brain. And eventually we came out with about 65 different areas of the brain and 5 biomarkers, essentially markers that we would look at and go, okay, do we see signs of an injury, a persistent injury in this patient? Now we do a similar type of scan that takes 12 minutes. So that's really nice, especially for those of us that have a little bit of claustrophobia. And we get currently 27 biomarkers. Now this is still evolving. You know, we may throw away some biomarkers that aren't clinically useful. We may add more, but I like to think of it almost like we're zooming in on very small parts of the brain and able to see in such more detail what an injury looks like for each individual patient.
That's awesome. And is this 12 minutes on top of the 45 minutes, or this replaces the other?
Completely replaces. You're in and you're out.
Interesting. So, Alina, tell me about the type of people that, or the type of research that you had been doing before you switched to COVID.
So Jaycie and I have done, we've written a lot on concussion, right? And we still do. Concussion is still kind of our bread and butter. You know, we are actually a concussion clinic. But with that being said, right, I mean, there's things other than concussion out there. And with a lot of this kind of the emergence, so to speak, of COVID-19, you know, we were one of the first clinics out there because patients were contacting us. They would be looking at our post-concussion information and going, well, these are my symptoms, you know, but I didn't have a concussion. So we were getting inundated by patients with COVID, and then of course with long haulers saying, well, can you help me too? Because these are my symptoms. And we did not say no. You know, we said, okay, well, let's scan you. All of our stats are based on concussion, but if we show some, you know, abnormal neurovascular dysregulation or whatnot, then we can treat it, you know. But we were very transparent with our patients that we were a concussion clinic. But yeah, and then the word just started, you know, to spread because we actually, especially with Gen 2, and I know Dr. Loewen wants to talk about this, but it seems like the sensitivity of generation 2, or this new Fmri that we have, seems to be even more sensitive to COVID than even to concussion at this point. You know, it's kind of interesting how that came about. But to be fair, Katherine, we still see mostly concussion. About a fifth of our patients, maybe maybe 1 or 2 out of every week of our patients is a COVID patient. But then we also have patients that have dealt with strokes, have a TIA history, carbon monoxide, chemo brain. You know, Jaycie, can you list more that I'm forgetting? But you know, the list goes on. We don't just do concussion. We basically specialize in any type of neurologic issue that looks totally normal on regular imaging, but that patient knows something is wrong. That way, when we look at how the brain is functioning, that's when we can actually see the deficits on neuroimaging.
Yeah, as we're going to allude to as well, I mean, bacterial and viral meningitis, you know, those were patients I was surprised they did end up reaching out to us because their doctors had told them, well, I've never seen this before. This is strange. You shouldn't be having brain fog. You know, you shouldn't be having this and that. And then we end up scanning them and they look like they've had a physical trauma to their brain. So we get some really interesting patients coming in, but luckily with objective imaging, you can look past the symptoms and actually figure out what's going on.
And Jaycie, someone just asked, you know, do we see it with autoimmune?
So there are. So one example that I will give is that sometimes it can be very complex because let's say that someone has a history of brain injury, and brain injury is associated with immune changes in the body. So actually brain injury is thought to be able to propagate certain autoimmune issues if you have maybe the genetic predisposition for that. But we've even scanned patients that have multiple sclerosis, which is thought to be, you know, an inflammatory type disease. and their brains do not look normal. They don't look like a concussion brain, but they definitely show signatures that, and to take a step back, what we look at on that functional MRI is what's called neurovascular coupling. It's how the cells of your brain, which are always talking to each other, receive energy. The brain isn't like any other organ in our body. It can't, for example, like my muscle can eat glucagon that's around when I'm doing a workout. My brain can't do that. It can't eat itself. It has to directly get energy from the bloodstream in the form of oxygen, glucose, and all this other stuff. So if your neuron cells are decoupled from the vasculature, so how energy is transported through the bloodstream to the cells, that's where you end up with symptoms. So yeah, absolutely, with multiple sclerosis, we're seeing this decoupling where it's like, we need this brain area to work, but it's not getting the juice to it to allow for that.
And then sorry, go ahead, Katherine.
Go ahead.
Go ahead.
I was just going to say, and then so from that example, when you then look from a functional MRI, what are you actually seeing in the report?
Yeah, we actually have an example we'll show a little bit towards the end, but what we do is that we translate that information into a comparison to a healthy normative population. So if I go to the doctor and I get my blood pressure tested, I'm going to be compared to a normative population. So we can actually tell, is this higher than normal, lower than normal? We at Cognitive FX have a normative population. So thousands upon thousands of images from healthy individuals where we can build a bell curve, so essentially kind of the variations of normal. Everybody looks a little different, but we can also figure out, okay, this patient does not look like a normal brain. And so how we've represented on a document currently is that we show patients, okay, are you in the green? Are you within normative limits? Or are you in the yellow, moderate, mild to moderate limits, or in the red, which is severely outside of the norm? And so it's a real nice visual, because patients are like, okay, if I look at an entire brain, I don't have a neuroscience background. I don't know what I'm looking at. So we try to translate it into layman's terms and it basically educate patients on what's going on in their own head.
Did you want to show those slides?
Yeah, so we just have one, and this is like fresh off the press. So the people in this room are getting access to information that's brand new.
And don't worry, Margaret, this is just a sneak peek. Okay.
Okay, so I'm going to share my
And then can you describe it for the podcast version?
Absolutely. So I can't share my screen. I think the host needs to give me permission, but then absolutely I'll do kind of an audio over. Okay. Alrighty. All right, so what you're looking at in front of you, is everybody able to see that? You see lots of colors, green and red?
Yes, that's clear.
Perfect. So currently on our version of the functional MRI, we're looking at what are called functional systems. So when we're looking at a brain, these networks light up. So one brain area is lighting up, but in order to complete a task, the brain will usually light up multiple areas at once. And kind of think of like a company where it's like, okay, you've got this department that works on this kind of thing, and you got that department that works on this. So we call those functional systems. These functional systems can help us do everything, to look for the milk in the fridge, to take a walk while talking to a friend, to being on this call and listening to Alina, myself, and Katherine talk. So off to the right, we're not going to go through all of them because there's 27. That would take us the entire rest of the time. But to give you an idea of what our patients are able to see is that this is actually a COVID patient. This is someone that had COVID. I mean, this is an individual who was the CEO of companies, who was involved in his community and then got COVID and was unable to function. These functional system scores off to the left, you see all that green? There's a lot of types of normal. I mean, everybody's got a unique brain. But as we see, as I mentioned before, as those scores start drifting away from normal, as they start drifting off to the right, you can see these high red scores. So this is where we're seeing that neurovascular decoupling. We're seeing that injury as it's manifesting in the brain. And this isn't the only report that we give our patients. It's actually like, 30 pages long, so we give them all the details. But this is the first piece where we as a neuroscientist or neuropsychologist or therapist in the clinic go, okay, here's where we're starting. Here's what we need to work on. And it's also very validating for the patients to go, oh, wow, that's a lot of red.
So let me Let me make
But-
sure that let me just try to do a layman's version. So what we have in front of us is a graphic that has green on the left side, moving to yellow, then to red, sort of like stoplight colors. And the green section is very large, and anything where there's a black mark in that green section is normal, showing that there's a whole range of normal. Yellow is sort of a warning sign of less than a normal, and then the red is where there's a deficit. And then along the right column are all of the different tasks that the patient has done within the functional MRI, so that this graph shows where that person's ability is sort of pegged to other scores. And in this, you're using brain injury scores with this COVID patient, and then where that mark is gives them an indication where that scan shows that their ability is compared to other norms. Is that right?
Yeah, that's exactly right. And Katherine, just to kind of elucidate for those on the podcast, we have 1 through 27 biomarkers. Let's just name a few, just so you can kind of have an idea, okay? One of them is, for example, attention selection, okay? One of them is nonverbal working memory. So your ability to remember and kind of hold things in your memory that aren't words, okay? So nonverbal. We have object identification. We have declarative versus episodic memory. We have a verbal fluency, a word retrieval, attention shifting, etc. So we're looking at 27 different biomarkers, or kind of the things that we almost always see going wrong with COVID or concussion patients.
And if you've had a neuropsych assessment and ever played those games or looked at the picture or had a word list, and then a couple of minutes later you're asked the word list again, these are traditional questions that one would be asked in a neuropsych evaluation. It's just a functional MRI, and somebody's looking at what part of your brain is lit up at that moment when you are doing that task.
And that's exactly right. And we just got a question saying this looks a lot like neuropsych. Well, because I am a neuropsych, right? We wanted to create a way to convey this information that wasn't scary, right? Because the minute you say Fmri, you think, oh my gosh, I got to get a degree in advanced neuroimaging. I said, well, yeah, or you could just have a neuropsychologist relay this information in a way with standard deviations and norms and absolute values, right? Way that makes sense. But one of the things that really makes this different from neuropsych paper pencil testing, okay? I am a neuropsychologist, right? So I know paper pencil testing inside and out, is that for lots of our patients, our concussions and our COVID patients, they'll usually do fine on paper pencil testing, okay? A lot of times they're just normal on neuropsych eval. And can you imagine how invalidating and frustrating that can be for that patient? Their MRIs are normal. They're like, okay, well, that's good. Okay, then you don't want a tumor. But then when you're doing an actual test and they're like, well, why is this saying that I'm within normal limits? You know, I know that I'm not okay. Here's the biggest difference. That neuropsych paper pencil, all I'm really interested in is whether or not you're getting that answer right or wrong in a certain time limit, okay? You're probably gonna get it right. But what this test shows is what it's costing you to get that answer, okay? How hard your brain is having to work to get that answer. Is your anterior cingulate supposed to be activating, but actually it's your posterior medial frontal that is kind of taking more of the burden, you know, because your anterior cingulate isn't working correctly? That is what this is showing us. So when you think about it, it is just opening that black box, okay, which is your brain, and really looking at what's happening rather than I got the right answer in a certain amount of time. Does that make some sense?
From my experience, going through, and I just did the testing period. I did the first, I did not do the treatment. I didn't do the follow-up. I just did the initial test period. And I know that with I feel like I'm very strong with my visual characteristics. I think also as a dyslexic, I really rely on my visual because my audio will let me down a lot of the time. But it was interesting because you were talking about that you could see that I scored very well in those sections, but at a cost to myself. You could respond about me. That's fine. I give you permission.
Yeah, exactly, Katherine. And that is what's so validating about this. And I have to say, Allison also, she's in the chat, she said that was exactly her experience, is that, you know, you can pass, you can do so well, right? Because Katherine, if you're dyslexic, your brain has just found another way to rewire in order for you to function, you know what I mean? And obviously you can function quite effectively. But what this is showing clearly is that your brain is not wired like a normal brain, right? And I mean, if we're going to be, you know, Katherine said we can share, but yeah, there are some parts of our brain that we're working overtime to compensate for other areas of our brain that should have been working, even though structurally the tissue looked totally normal, you know? And I think that is why advanced neuroimaging is going to have such a huge role, especially in these types of disease processes or injuries where everything else looks normal, you know, to be able to finally say, well, they were wrong because this is functionally how it's working and not working. That is so psychologically, emotionally, physiologically validating, you know, for our COVID patients and for our concussion patients.
And I have to say, I mean, I always say that the most valuable thing that I have pretty much ever said to the women that have come to talk to me, over a couple thousand now, is you're not bad, crazy, stupid, or malingering. You know, from what you told me, it sounds like you have a brain injury. And the person on the other end cries and says, thank you for believing me. And I think that's how I've always hung my hat on the hopes that imaging is going to show us, you know, what we already knew as patients, but we couldn't, you know, explain to spouses, children's, employers, you know, on insurance companies down the line. So that's why imaging has always been incredibly important to me. And while I didn't have anyone else to share that information with, or anyone that really cared, you having that experience and understanding that helped me personally as I navigate how I'm going to use my energy throughout the day.
Yeah, thank you. Thanks, Katherine. I mean, it's honestly people like you and people like Allison, and we've treated over 3,000 patients now utilizing this tool. And, you know, that's honestly what keeps us going. We know that we're different, you know, and we know we're not for everybody. And people get asked, like, even in kind of the legal realm, right? Well, you know, you're using Fmri for diagnostics. And I said, no. Actually, I don't even use Fmri for diagnostics, for diagnosing concussions, because honestly, Katherine, any doctor that's trained can diagnose a concussion just based on a clinical interview, right? Just talking to a patient. So I think it'll get there. You know, I really do think it'll get there. But Jaycie and I will tell you what this is valuable for is not telling you whether or not you have COVID or long haulers or concussion, because you know that. But how do I help get you better? That's the most important thing, right? Is, you know, when people like you, like Allison, like our 3,000 of the patients are coming begging us to help them feel better, this is exactly what guides us to that. So Jaycie, if you want to throw up that screen again, you know, if we can see exactly which areas are not functioning well, okay? Like, for example, you know, if I know, so this is just a screenshot. Please come to our presentation in September. It's September, right, Katherine?
September, I can't do something. IAM and NABIS, and the conference will be in New York City, and I think it's the 28th through the 30th. I'll make sure somebody puts up in the chat, and we will be in person in New York City. Concussions,
yeah, but
thing, and Alina and Jaycie will be presenting their research.
But please come, because we're going to show you the other pages of this test that actually break down each of these biomarkers into different structures that we're looking at. So knowing exactly which structures are working well, which areas are maybe over relying on its neighbors, right? Which areas are just not firing. That directly guides our treatment, and we stimulate the areas that need more blood flow. We can destimulate and take away blood from areas that are overutilizing, or kind of like we say, gas guzzling, you know, and kind of stealing gas from other areas. And we do about 1 to 2 weeks of treatment, right? And at the end of that week, you get another scan that looks like this. And we can actually see which areas are responding and rebounding and feeling better. And yeah, it's just a great tool to use. It's a clinical treatment tool for us.
Looking forward in the future, and again, I mean, I think you and I and Jaycie are, you know, understand how imaging is important. This is something that needs to be funded at NIH. It needs to be, you know, at Capitol Hill. When in brain injury people go up to speak at Capitol Hill, we need more imaging out there, because the imaging, I really feel, is the key to opening so many doors on so many levels. What would you like to see generally happening in the future in TBI, Alina, then Jaycie? Like what would you like to see in the future? And then we'll switch to questions in about 3 minutes.
And then we'll actually switch to COVID questions. Is that what you, yeah. Okay, well, let me get my soapbox here. So,
or both COVID, brain injury and COVID, like what, you know, your minute and a half on the future.
So I got to tell you, I don't know if I can say it in a minute and a half. I'll do my best, but you know, this has been a long road for me. You know, you can see I'm not a white male. I am a woman of color. You know, I'm a woman that, you know, I'm Native Hawaiian. I'm Asian. I'm Native Hawaiian. Like you know, things have been hard. And I remember when I first started off with my research, presenting this stuff 15 years ago. I mean, I've told Katherine this. I remember being so happy to finally get in a symposia, finally be able to not just do a poster presentation, but be able to talk for 15 minutes in front of my colleagues. And, you know, in sports medicine, it's mostly men. I'm going to be really honest, right? But to be able to get up there and say, hey, guess what? There's new imaging data. And by the way, concussions, we shouldn't cocoon them. We need to actually exercise them. Let's get them out of the cocoon. Let's get them. I mean, I've been, you know, laughed out of rooms before. I've been told by colleagues, not friends, just colleagues, that I'm going to kill my patients. I've had people walk out of my presentations. This is, you know, 15 years ago, 12 years ago. All I wanted at that point in time was to be able to be heard without being ridiculed. Come now, you know, I've been practicing 17 years. I mean, now, you know, active treatment, active therapy for brain injury is now the gold standard, right? You're seeing all these papers coming out saying, yeah, we need to get out. We need to exercise. We need to, you know, I still think we should cocoon for a couple days at the most, but after that, get them out going. I really want there to be more open-mindedness with regards to how brain injury people are seen and how treatments are seen. I would really love, I mean, we've never been funded by NIH. We are a private clinic. The reason why is because, you know, I get asked, well, where's your, you know, we need to see your big studies. You know, we need to see where your comparison studies, where's your this, where's your that. And I'm like, I don't have that luxury. I have a clinic where people are banging down my door saying, treat me. I cannot tell one person, yeah, I'm going to treat you, and do placebo effect for, you know, or just do kind of a, you know, randomized to no treatment. And these people get treatment. I don't have the luxury of that, right? So I realize that, you know, we are limited with our science with that. You know, we don't have like an RCT or a randomized controlled trial that a lot of these, you know, big funding need, you know, they need to have that to get the big funding. But I would love for someone at NIH to say, this is still valuable, right? The fact that we're still treating people and not rats, right? No offense to Dr. Loewen, right? But I mean, that's why she works with people. People are the most important thing. If we can get you guys better, if we can make a difference in your life, that data is very, very valuable. So I think in a minute and a half or 5 minutes, whatever, how long it took, I would love for that to change. I wish it wouldn't have taken 10 years for that attitude to change. I would love more open-mindedness, more acceptedness. You know, that's a word. I want more acceptance, and I would love for everyone to embrace that there are other modalities and other imaging that are just as valid.
Absolutely.
There you go.
And I do want to remind people that from a paper to practice is about 15 years. So if it takes 5 more years to get, that done, then it's another, then that's 20 years out until it actually gets into practice. And it takes that long. It really, and you think with Twitter and everything else that, how could it take 15 years to train doctors on what research papers are saying? But it really does. And I want to give Jaycie a chance, and then we're going to switch off researchers asking questions first, and then patients asking questions every other show, so that we have different groups. So Jaycie, your moments, and then we'll switch over and see if there are any questions from researchers and medical professionals.
I completely agree with Alina first and foremost, and just want to follow up with, we need to get to a point where we are individualizing treatment. I mean, so often it's this cookie cutter, okay, well, you're of this age, let's try it, or of this gender and of this weight, I don't know, maybe let's try a medication. Or, okay, yeah, go cocoon. We need to get to a point where we have advanced enough technology to be able to identify what a certain individual needs, how they're going to benefit from it. And this is something that, we do at Cognitive FX, but we're still improving. Our protocols probably change every 3 months because we learn more. We're keeping up with the research. We are learning from our patients. So this accounts for, yes, concussion, but also COVID. We have completely had to overhaul protocols just for our COVID patients. So when they come to us, when they first came to us, it's like, okay, you're just going to get the concussion protocol, versus now we're actually developing COVID protocols where we legitimately have patients that are telling us, I am completely cured. I spent 1.5 to 2 years with this COVID, and that's like, okay, it worked. In addition to that, not discounting when treatments don't work, because it's not just functional MRI. Like, we love this tool. It is the foundation of what we do, but we have patients that have hormone changes after their concussion or COVID. They have visual changes, even ones they might not notice. We had a patient come in who reported no visual symptoms and had no peripheral vision. She could only see straight in front of her. Vestibular changes that can cause balance, dizziness, etc. So it's treating the whole person. And even though we could even have a patient that maybe comes in and their scan isn't that bad. Their functional MRI is like, okay, it's not pretty. We still need to work on it, but it's not that bad. That doesn't mean we're going to go to that patient, oh, you don't have it as bad as others. No, we're going to go, okay, what else could be causing your symptoms? Let's look at all of these other factors. So I think individualized medicine, evidence-based medicine is some of the next steps that we need to start taking now. I mean, when Alina mentioned we have patients knocking down our door, but not to end on a sad note, but I wonder how many people we've lost because they didn't get help.
Well, thank you for that, for both of you. Maybe Jaycie, you could scroll through the chat and see if there's any questions that we missed. And then so we'll start this week with if there are any medical professionals or researchers that want to ask a question first, to put your hand up. And then another minute for that.
Can I just
sure
take over for a second? I'm just wondering, so I realized that there's actually 2 people who came to CFX here, but I won't name the other one because she hasn't, she's not, she didn't post it on the chat. But Allison, is there anything you'd like to share? She and I have been kind of chatting through. Can I do that, Katherine? Can I ask her?
Absolutely.
I, as I said to you in the chat, I'm always happy to talk up CFX because I really enjoyed everything you guys offered there. So I could say a lot. If anybody is interested in any particular aspect of the experience of actually being there, maybe that would be a good place.
Great. And just to know, we didn't know Allison would be here. She's not a plant.
Allison's here every week. Allison's a loyal listener. So
true.
Nat, you had your hand up.
Hello, thank you. It's a very interesting presentation. I was wondering if you had any interface with some of the diplomats that had been exposed to some kind of field that they then noticed that they had brain fog and brain injury, if you'd had any interface. And I'm sorry, I'm not remembering the name. I think it's called Havana syndrome.
Yeah, I've actually heard of that. We had one consultation that came through that mentioned that he had Havana syndrome, but this was a couple years ago. But I don't actually remember ever treating one or scanning one. Dr. Loewen, do you?
No. Well, I actually recently did a consultation with another patient that had mentioned it. Unfortunately, wasn't able to go through treatment just to certain other pre-existing conditions that they needed to resolve. But if you happen to know someone that would be a good research participant, that's able to get into that scanner, we'd love to take a look.
Thank you very much.
I put a paper that I had just texted to you, Alina, yesterday that came out about mild COVID, people where they didn't really have symptoms during their COVID session, their moment of COVID, their whatever period we're calling COVID now, and then are showing memory issues later. Now, I'm on my 12th day of COVID right now, and definitely see some struggle, definitely see some struggles in sort of the COVID phase. I have had chemo brain from chemo, and I have had traumatic brain injury. So at this point, hopefully the COVID memory issues aren't part of my piece. But what in those categories that we saw, those biomarkers, have you seen, the people with COVID that have come through really struggled with?
Well, I'll start, and then Jaycie can lead in as well. But just so you know, Katherine, when you did send that to me, the first person I forwarded that to was Jaycie, right? And so I sent that to her, and she and I then persisted to have a little conversation about this in particular. But this doesn't surprise us, right? This is what Jaycie and I have been seeing for the last almost 2 years, right? Because we've been seeing COVID patients kind of as soon as COVID started, and there's so many similarities between COVID and concussion, not just in the symptom presentation, but in the understanding of it, because on brain imaging, COVID patients look totally normal, right? And so we're going to see, I think, a lot of these long haulers with even mild, like you said, with kind of the mild symptoms, with these kind of long range memory issues that may never have attached it to the COVID, right? They might notice years later, gosh, something's not right. What's going on with me? We might have people that are going to their neurologist now, and they're getting diagnosed with, MCI, mild cognitive impairment, or, like an early onset dementia, when it could truly have been a neuroinflammatory effect from their mild COVID that might be treatable, if we can actually see it on imaging. So I know that a lot of the markers that we look at, of course, would be, some of the memory. And like I said, with this new scan, we can actually look at different types of memory. We had verbal, nonverbal memory. We're looking at episodic versus declarative memory as well. But yeah, we're definitely picking up some of those issues with COVID. Jaycie?
Yeah, in some sense, our COVID, again, we're basing this off of the new scan, but it seems to be systemic. I mean, it seems to affect multiple different systems all at once and how those systems interact. What's really interesting is that there's research, I think it was a paper that came out last year, but we like to think about the immune system and this immune reaction, but in all truth, the immune system responds to the virus, but it seems that it's this combination of the virus, the immune reaction, that causes basically just a miscommunication between the cells, the neurons, and the vasculature. So that doesn't mean that you need to go into the doctor and they go, okay, now you have an autoimmune disease and this is the cause of your symptoms. You can get a full immune workup and you're just fine. You can get a full vascular workup and they're going, well, there's really nothing wrong. The people that tend to get long COVID, we're coming up with out some statistics. They tend to be females, 35 to 69 years old. They tend to be individuals with underlying conditions that limit their activities during the day, those that work in health and social care, and those that live in poorer areas. So we're going to have some sensitive populations that are going to start appearing with, well, I just had a sniffle and now I have long COVID. What's going on? We did have a really good question also about people that might be more at risk, for example, those in poorer areas, the homeless. Absolutely. And it's going to be very hard to recognize possible COVID symptoms in these people because, again, they may have a pre-existing condition. Let's say that they do have impulse control issues that are related to drug use and they get COVID. We have a lot of our COVID patients that develop attentional issues, impulse control issues. So it's like, okay, how do we figure out when people have developed this long COVID? How do we figure out how to fix it in some pretty complex populations?
And it's definitely fascinating work and so important, I think, as we move forward with COVID, that resources are developed for identification of long COVID and rehabilitations. Having Omicron, the symptoms that I personally experienced, which was sore throat and a cough for maybe about 3 hours, but nothing, no congestion, nothing how I thought COVID would be, and then got a positive test, was really so surprising. I think it's really important for people out there to definitely test. I use the home kits, and to not neglect a cold. And I know we're all kind of burnt out on it, but I think it really is important to know whether you've had it and to continue. We have a few minutes left. Just trying to read it. Incredibly intelligent questions in the chat. And as always, I will copy the chat and we'll send that along to you, Alina and Jaycie, so that you can see any of the questions. And if you want to put your contact information in there, that would be great too. If there are no more questions from the audience, put your hand up if you'd like, and then Jaycie, we'll start with you. Anything else you want? Oh, Nat, question from Nat.
Thank you. One of the things that I'm seeing in mostly female and mostly in the age group of 50 to mid and late 70s is COVID, then social loss of routine, and then very quick onset of dementia type of symptoms. And so I'm seeing the psychosocial as well as the loss of routine and the loss of interface and almost like then loss of language. It's like the storm of the psychosocial along with the COVID, and then comes the denial. Nothing's really wrong with me, but their whole life has fallen apart. It'll just be interesting to look at that as we move through the COVID pandemic.
Nat, it's almost like you got a sneak peek at our presentation in September, but we actually we have a great slide that shows up bio, psycho, social, emotional. I mean, there's this whole model for COVID, right? Because it's so different from anything else our world has ever experienced, right? That there's so many other factors that are contributing to the symptom profile that you can't ignore. And Jaycie and I, we go ahead and kind of break down all these kind of different factors and different models, and why this is so damaging on so many levels, and not just to adults, right? But I mean to children, and children probably even more so for those of us who have children that are growing up in this, but you cannot ignore all of those factors that are contributing to what COVID really is.
And somebody put in the chat about the difference between various variants and the risk for developing long COVID. I mean, I'm in the Omicron class of COVID versus the Delta group versus those that had no vaccines. a year ago. So, and there are differences. I woke up one day and had sores all inside my mouth, thought I was going crazy, went online, and there were all of these people with Omicron with sores. 2 days, I barely could talk, and then third day completely gone. So unless I had gone on and read articles about this, you really start to think you're insane. So my COVID experiences seems very different than when I was working in COVID a year ago. I've had no respiratory issues in the slightest. So there may be these certain classes of, which variant you got. And hopefully by the time we get to your presentation in August, Alina and Jaycie, you've had time to study that.
So it's in September. Give us enough, don't take away a month.
September, sorry.
Yeah, it is in September, and we would love to, I was talking to Jaycie about this just now, and between now and September gives us a good amount of time to get some longitudinal data. So we're definitely going to get some of these COVID patients back in the scanner and start doing, following them over time. I'm sure we're going to have some preliminary data on Omicron, but Omicron's so new, right? Delta is still relatively new. So it'll be preliminary data, but it'll be data, right? But, Jaycie and I have given a variation of this COVID talk, I feel like a dozen times, and each time it's different because something new came out, new data, new research, this is going to be organically evolving like a virus evolves and mutates, but the nice thing is, you don't really ever get bored because what Jaycie and I speak about is always something new.
Well, I want to thank you both for being on our show, and we'll send out the video from this show next week. I did want to point out that if you're in the US and you have a senator, it would be a great time to reach out to your senator about the Violence Against Women Act, and that we'll send out some details on that. It's really simple. You just call up your senator and ask them to support the Violence Against Women Act, which we've talked about on our other show. Also send some information about that, and in the chat about the upcoming IBIA and NABIS event in September in New York, where you can see more of Alina and Jaycie. So thank you both for being on the show. You'll each have about 30 seconds to have a last moment, and then we will say goodbye to our audience.
So just real quick, a shout out to Jason, who's also a Kameme Gradi Mo Kameme. He's been chatting on the chat. Real quickly, with Brazilian Jiu-Jitsu, I want to answer his question. It would not surprise me at all if we're seeing some neurovascular changes, especially with those types of contact sports. So Jason, mahalo, aloha. And thank you everyone for being here and supporting us. And thank you, Katherine Snedaker.
And Jaycie?
Yeah, no, thank you everyone for listening. And this is an evolving situation. We're so encouraged to have, I see 62 participants, and I think there were more at a certain point before people jumped off. So please, at least if anything, take away from this, that if you're noticing a friend or a family member struggling, consider this, consider COVID as a possible cause. I actually had a good conversation with a family member who suddenly was developing all these things. And my first question was, did you have a concussion? The answer was no. My second question was, did you have COVID? And she might be coming for treatment. So this is something that we can address. It's treatable. We just need to learn how to recognize it. But thank you all so much.
And thank you, Allison.
Yes, thank you, Allison. My homie for Astoria, Oregon, right?
Wow, very good.
Well, thank you, everyone, and we will see you next week for our next show. I think we're booked out now through April, so you all keep coming, and we'll keep doing these shows. So thank you, Alina. Thank you, Jaycie, and we'll be copying the chat for you and send out the video for everybody. Thank you so much. Have a great day, everyone. Stay safe out there.
Thank you.